Good morning, everyone. Thank you so much for having me. I'm Myra Zaheer. I'm a PGY1 ENT resident and co-director of partnerships for global surgery, and also a recent graduate from George Washington University. And today I wanted to share some of the work that Partnerships for Global Surgery has been doing, which is at the intersection of global surgery and surgical education, specifically asking whether we can measure learning in low resource settings and whether that learning actually sticks. So some disclosures, Partnerships for Global Surgery is the entity that organizes and executes the service, education, and research mentioned in this presentation, and all patients shown have provided consent for educational purposes. This work would not be possible without all of the wonderful directors on our team. Dr. Josh Wiedermann, who's the founder and CEO of Partnerships for Global Surgery, is the heart behind the mission. Cody Messick, who leads a lot of our airway, foreign body, and research initiatives, and Evani Patel, who leads our registry. Here's our roadmap for today's discussion. We'll move quickly through the global surgery landscape, establish the mission of PGS, and then spend the majority of the time on the research itself, the feasibility and educational impact of objective assessments, a brief look at our equipment registry, and where we're going next. You're likely familiar with the landmark 2015 Lancet Commission findings, where 5 billion people lack access to safe surgical care. 81 million people face catastrophic health expenditure just seeking that care, and the poorest third of the world receives only 6% of surgical procedures performed globally. These numbers frame the scale of what we're up against. But access is only part of the problem. The scatter plot shows perioperative mortality plotted against the Human Development Index. As HDI rises, mortality falls. Predictably, Ethiopia with an HDI of 0.46 sits at the far left. What this tells us is that we're not just dealing with limited access, we're dealing with a quality of care problem too. And this historical view reinforces that point. Ethiopia's perioperative mortality has been tracked over decades and remains disproportionately high relative to its regional peers. The infrastructure deficit is real and it's persistent. And this is what we call the global surgery paradox, a chicken and egg problem. You can't improve quality without better access, and you can't expand access without improving quality. And both pillars have to be addressed simultaneously, which is exactly what PGS tries to do. So how has the field responded? When we reviewed the published literature on short-term surgical trips in ENT and head and neck surgery, there are several gaps that became very clear. Very few studies focus on education or sustainability. Surgical outcomes are reported, whether positive or negative, in under 5% of papers, and lower and middle income country authors are nearly absent from the authorship list. So the evidence base is thin and inequitably produced. We also surveyed partner sites in Ethiopia and in Kenya to understand what they actually need, and separately asked visiting high-income country providers what they can realistically offer. And the mismatch is significant, particularly in advanced otologic surgery and sinonasal disease, but the gaps are not insurmountable. They're addressable with better coordination, which is what which is the niche that PGS occupies. So our organization, PGS, aims to increase safe and affordable surgery globally by building longitudinal bidirectional educational relationships that become self-sustaining through capacity building. And the key word there is bidirectional. Our lower and middle income country partners are not passive recipients. They actually are shaping what we teach, how we teach, and what we study. But here's the gap that motivates this specific study. Surgical teaching is happening on these trips. Residents observe parotidectomies, they suture, they attend lectures. But informal feedback is not the same as objective assessment. And without validated, reproducible tools, we can't answer the most important question, which is, did they actually learn? So we built a two-study framework. First is feasibility. Can OSATs and OSCEs actually be implemented during a short-term surgical trip in a resource-limited setting? And second, educational impact. Do structured assessments capture meaningful change over time? Our broader educational model maps 3 domains: clinical knowledge assessed with written exams, decision-making assessed via OSCEs, and technical skill assessed with OSATs. For this pilot, we focused on suturing as a model skill, which is a procedure relevant across different specialties and also teachable within a short curriculum. This was a prospective mixed method educational study. We delivered longitudinal 9-month curriculums built off of 2 4-week short-term surgical trips to Mekelle, Ethiopia in May 2024 and February 2025. 22 participants were enrolled, including local providers, residents, medical students, and visiting faculty. And assessments were administered at baseline, immediately post-trip, and 9-month follow-up. At baseline, we surveyed participants on prior training and exposure, and as expected, the cohort was heterogeneous, ranging from early students to experienced consultants. And this variation is representative of real-world teaching environment on these trips and allowed us to look at learning across different levels as well. We used a validated OSCE rubric adapted for sinonasal and head and neck surgery curriculums and an OSAT scoring sheet for suturing technique, and both were administered by blinded faculty raters. And this is a very feasible instrument. It takes under 10 minutes per learner, and there's no specialized technology. And these were our suturing results. Of the 13 resident participants, 7 demonstrated an improvement in score from pre to post test. 3 had no change, and 3 showed a decrease in score. So these data points are demonstrating a positive trend in suturing knowledge following educational intervention in May 2024, with further improvement or retention evident at 9 months. The increase in mean scores from 7.9 to 8.6 post-intervention and subsequently to 9.5 at follow-up supports the effectiveness of this intervention. And for parotidectomy, we saw significant improvements in multiple choice knowledge scores and in OSCE performance. Of the 13 resident participants, 9 demonstrated improvement in scores from pre to post test, 2 had no change, and 2 showed a decrease in score. So this is showing a positive educational effect of the intervention with a mean increase from 7.9 to 9.4 and further improvement to 10.3. And so these are kind of showing that the median scores and decreased standard deviation post-interventions, which is suggesting consolidation of knowledge amongst our participants. Synthesizing across the cohort, improved confidence across suture materials and techniques, significant gains in parotidectomy knowledge, and sustained improvement at 9 months. So that our educational intervention did work, and it was feasible in this setting. On a parallel track, we identified airway foreign body retrieval as a critical unmet need at our partner site. We are currently piloting a study in Uganda, which is led by Cody, Messick, and Sonia Shah. And basically, we surveyed equipment access using the Global H&S essential equipment list, and the majority of respondents reported no access to over 60% of the items, with forceps and telescopes of various sizes being the most commonly missing. And the estimated replacement cost is about $40,000. So this is the physical prototype. The team is currently in their validation phase with plans to pilot this device in Uganda this summer, and I believe that they've already started doing that. So what's the next phase of PGS? It's threefold: expanding our educational partnership with more complex skill domains and larger cohorts, using our longitudinal research registry to drive locally owned quality improvement, and integrating findings from Mekelle into our broader network across Uganda, Zimbabwe, Vietnam, and other partner sites. So to date, PGS has conducted quality improvement studies, and we've looked at delays to care, capacity, patient outcomes, and DALYs. Our work has yielded publications on cultural competency, gender disparities, and barriers to head and neck cancer care in lower and middle income countries. So this is just a snapshot of some of the work that we've done abroad as well as at international conferences. Thank you so much for your time. If you have any questions, feel free to reach me at myrazaheer@gmail.com.